in patients when you are doing the calcium score, if it is between 11 and 100 or a little over 100, would that be a criteria for you to start using statins and aspirin in these patients as a preventive?
That's a very good question. First of all, it costs a lot of money. Not, of course, if you work with the statins, etc., that are off patent, but still, if we're going to put, and it's almost never that you see CT scans that are completely blank. So you could even question yourself: is this just a way of aging the way we have our lifestyle, what we eat, and the limited exercise often to get a result in these phenomena? And the question is, should we treat all that or not? And so I think it's a very difficult question that you raise. And then also based on just a little bit atherosclerosis and no ischemia, should you revascularize? We do basically the combination between visual visualization of the stenosis and the ischemia. And then based on that, we discuss in the heart team and we take our decisions. You're asking about then, what about the statins? I think that's a very difficult question because the statins, as I said, have a lot of side effects. A lot of people don't tolerate that well. What the statins do, what we have been seeing in sequential CT scans, is that it mostly calcified the lesions. And so therefore you're not taking the lesions away, but you are sort of changing it from non-calcified to calcified. And we believe that the non-calcified is the pretty dangerous one, and the calcified is also dangerous, but much less dangerous. So therefore, if you give high dose statin and you calcify them, then it's probably a good thing for the patient. At the same time, all these new drugs that are on the market costing a fortune, and we see now here that we can, in terms of medical costs, we cannot afford that in all these patients.
Can I ask one more question?
It should be brief, sir.
Okay, as I think this is a very good imaging, the CT, FFR CT and IFR CT, but I guess you have to use plenty of contrast there. How safe do you feel in a 65-year-old, 20-year standing of diabetes with borderline liver creatinine perhaps slightly elevated? So how do you manage these patients? Do you feel happy putting in so much contrast in that?
No, I don't. I think we of course don't have any randomized controlled trials, so we cannot say so much contrast is good and so much contrast is not good. But we do see that every now and then we have problems with that. So I'm a little bit careful with sending everybody to the CT scan, because if we send all these people with a little bit elevated risk factor to the CT scan, we're going to get back that they're all having atherosclerosis. Then comes the point, how about then the expensive medications? Well, that we cannot afford as the way it's going to develop now. It's just going to be too expensive.
Thank you, Dr. Jerone. Thank you very much for your comprehensive talk.
Just one question. Somebody with a calcium score of more than 1,000, asymptomatic, and an imaging stress test is negative. Would there be any use of repeating the calcium score 2-3 years down the line, or would you like to repeat the imaging stress test as a follow-up?
I think I would do the imaging stress test because the way I see it is that the real problems with the atherosclerosis are the non-calcified. And that, I think, is very hard to do repeat scans just purely for that. So we still work very much ischemia driven. So if we see the patient at this time, then later on, usually we do a dobutamine stress echo because it's easier to do and there's no radiation. So we usually reach out to sequential ischemia testing. How do you do it in your practice?
Jerome,
Imaging stress test.
invariably, what I've seen is that if you have a calcium score over 300, 400, and you do a coronary angiography in them, you have coronary artery disease. And if you do a carotid ultrasound, you will find a lot of plaques there. So I think that as the calcium score increases, then you don't do a CT angio, you do a coronary angiography.
Yeah, and if the patient is totally asymptomatic, what are you doing then?
So probably an imaging stress test would be a very nice thing as a follow-up, like a CMR.
Yeah. Yeah, we do basically the same as you do. So the first test is atherosclerosis. Then we follow up with the patient. We give medication if needed. We follow up with the patient. And then if there comes chest pain, we do ischemia testing. I was at a big meeting not so long ago in Finland where there was a lot of people available, all speaking about CT and when do you do it and when do you not do it. And there were a lot of people working very advanced in this CT scan business. And I think that it's not clear actually how you should bring all this information together. We simply don't know. Are the infarction coming mostly from the non-calcified and therefore we need to treat aggressively? We think yes, but that is not the majority. The majority is probably from rapidly progressing calcium and resulting in ischemia. So it's either this inflammation on the non-calcified or it is the ischemia that develops on following the severity of the stenosis in the vessel. So it's two components. It's either the inflammation or it is the ischemia. And these two are hard to put that together. Then people reach out to the artificial intelligence and they come with results, but it's very hard to understand completely what is now the way to do in terms of sequential testing. And based on the results that we find, what should our action then be? So I think what you propose is very valid, and that's also how we do it in the clinics.